For more than 2 years, I've been publishing so many different presentations in medical field. Today, we'll be going through A to Z when it is all about hypertension. So, the topic today is what you are familiar with, but how much have you known? And what are those questions that you've been asking people around, or some wrong assumptions already made? But before diving deeper into this topic, let me welcome you, by saying thanks for visiting, remembering to subscribe, sharing all my presentations, and listening to this very one. Hypertension is a worldwide problem affecting more than 1 billion people worldwide. So it is a time well spent to listen to everything on hypertension. Well, the question is, why do we need to study anything about hypertension? The answer is simple. It is a serious problem affecting many people, and if you can do everything not to be involved, that would be great. And to those who are already involved, how can we help them? Epidemiologically, greater than 1 billion people are living with hypertension. Millions are dying every year due to hypertension itself and its associated complications. Billions of dollars lost due to decreased productivity, might be because of the morbidity and sometimes even due to mortality, and also a lot of money lost due to treatment cost. This level of loss, this colossal loss, is preventable in most cases, though 25% of well-treated cases will still end up in the above data, either in morbidity or mortality. Hypertension will have us look into genetics and look at individuals completely vis-a-vis all the systems from head down to the toes, and also the environment, the relationships, job, diet, stress, and so on. Now, you can see the image of the heart and some blood vessels. The inferior vena cava brings the blood to the right atrium. Superior vena cava will do the same from the upper parts of the body to the right atrium. And then there will be that contraction. The content will empty into the right ventricle. Then another contraction will force the content into the pulmonary artery. It is an artery because it's taking the blood away from the heart, and it's called pulmonary because it's related to the lungs. So pulmonary artery going to the lungs. Then reoxygenation will occur, and then oxygenated blood will come through the left part of the heart. The chamber here is the left atrium. Then the contents from the lungs will come to the left atrium via pulmonary vein. They are called veins because they bring blood back to the heart, and called pulmonary because related to the lungs. Then contraction will occur and the content will be pumped into the left ventricle. You can see how thick the ventricle is here. The right ventricle is also thick. The atria are not as thick as the ventricular chambers, but the left ventricle is thicker than the right. Okay, let's leave that aside. So the content here will be pumped from the left ventricle through the aortic valve into the aorta and then to the rest parts of the body. So this is how the heart would do its work on a good day. But there are a lot of troubles along the road when the blood is going through the aorta to other smaller vessels up to the capillary bed. Types of hypertension. And someone will ask, so do we have different types of hypertension? Yeah, many people along the streets will be familiar with high blood pressure, hypertension, thereabout. You are making reference to just one. That is systemic hypertension, otherwise known as systemic arterial hypertension. But more than that, we can have pulmonary hypertension in the lungs, ocular hypertension, no, needless to say that's referring to the eyes, no, with increased intraocular pressure, portal hypertension, no, from this, no, referring to the liver, right? Gestational hypertension from this referring to pregnancy, otherwise known as pregnancy-induced hypertension. So we can have all this, but today our focus is on what you are familiar with, systemic hypertension. Okay, the systemic hypertension could also be broken down to so many different types, but majorly two: essential hypertension or non-essential hypertension, otherwise known as primary hypertension or secondary hypertension. Now, let me stay on this alone. Essential hypertension is the old name, now known as primary hypertension or idiopathic hypertension, when we cannot really come down on a specific cause or causes of that hypertension. And that is accounting for about 95% of cases of hypertension in all human beings. So it's now known as primary hypertension, formerly known as essential hypertension, but could be referred to as idiopathic because we can trace the cause. But secondary hypertension or non-essential hypertension means there's hypertension right now due to a particular medical condition. We must trace the source here. So later on, we'll be dealing with possible complications of the systemic hypertension, either from primary or secondary. And that could include resistant hypertension. I will not waste your time, we'll get to that. Malignant hypertension or accelerated hypertension, we'll get into that. Hypertensive emergency or hypertensive urgency, we'll get into that. Hypertensive heart disease, coronary heart disease, heart failure, atherosclerosis, we'll also get into that in a bit. Hypertension simply means high blood pressure, and that means there is higher than normal blood pressure for the age and the gender. Blood pressure is not fixed. It's not fixed for a day, it's not fixed for any time. It fluctuates based on many factors. For example, a little stress somewhere, too much exercise, anger suddenly, fear suddenly, sudden drugs already taken, even a cup of coffee, all could alter the blood pressure momentarily. But elevation persistently is the key when it comes to the diagnosis, meaning all these could alter the blood pressure within minutes, but that will not force us to make diagnosis of hypertension. However, when the blood pressure is higher than normal for the age and gender, then we can make the diagnosis of high blood pressure or hypertension. The diagnosis is necessary because wrong diagnosis will lead to unwarranted medications being given to that individual, and that could be detrimental. And misdiagnosis could lead to complications of the hypertension without being treated. Now, the older you become, the higher your blood pressure expectedly. Not necessarily so in everybody. You know why in a bit. Okay, we'll take the BP in the morning before eating or before taking any of your medications. Also, at the evening time. We'll get into details in a bit. BP rises close to the waking hours every morning, and it peaks at the midday, start dropping in late afternoon. Some have morning hypertension. We'll get to that in a bit. Blood pressure and circadian variation. The BP drops while sleeping, rises close to waking up. Medications can alter this pattern, including certain diseases that can alter them. Morning hypertension is associated with more complications. Extended release verapamil is currently on trial to handle early morning hypertension. Still, by way of definition, we'll briefly examine cortisol level and blood pressure. Well, cortisol rises at early hours of the morning, just as the time that the BP will also rise. Cortisol will peak at about 6 to 7 a.m. and it is regulated by hypothalamic pituitary adrenal axis. It shoots up at early morning, and cortisol is a major factor in the timing of early morning high blood pressure. Now, if you want to tell me that cortisol level is irrelevant to the value of your blood pressure, then can you explain these two phenomena? High cortisol level in Cushing's syndrome is a known fact, right? But remember, Cushing's syndrome that will have high cortisol level will have high blood pressure. Okay, if you are still confused, cortisol is significant. Look at this. High cortisol, high BP, Cushing's syndrome. Low cortisol in adrenal insufficiency will give us low blood pressure. So low cortisol, adrenal insufficiency, treated with hydrocortisone will give us low blood pressure. High cortisol, Cushing's syndrome, high blood pressure. So in summary, cortisol level is a strong determinant of the value of your blood pressure. But that is not the only factor. There are so many factors that will contribute to the value of your blood pressure. We'll know them in a bit. So, blood pressure means that the blood is exerting pressure against vessels. That pressure exerted is known as blood pressure. Systolic blood pressure is the pressure in the arteries when the heart beats, when it contracts. Diastolic blood pressure is the pressure in the arteries when the heart is at rest, the diastole. It is estimated using systolic value on top of the diastolic value. Formally, we usually say anything greater than 140/90 millimeters of mercury is hypertensive. That was in 2003 guideline. Now, anything greater than 130/80 millimeters of mercury is diagnostic as being hypertensive. Don't worry, we'll go through the stages in a bit. This new value, 130/80 as the cutoff, is now in 2017 guideline on hypertension. Now, there's systolic hypertension, there's diastolic hypertension, and it could be both. Systolic hypertension, when only the systolic part, the upper part, is greater than normal for that age or gender. Diastolic, if the only one below at bottom is the one high, and both when both are high. Now, accurate diagnosis of hypertension. Okay, blood pressure stages and categories 2003. Normal value as far as 2003 guideline is concerned is anything less than 120 over anything less than 80 millimeters of mercury. Pre-hypertension at this time was 120 to 139 over 80 to 90 millimeters of mercury, and that would be termed as mild. Stage 1 hypertension is anything 140 to 159 over 90 to 99 millimeters of mercury as moderate, while anything that is greater than 160 systolic and over greater than 100 millimeters of mercury diastolic is severe in 2003. Now, in 2017, the new one, right? Normal is still the same like 2003, less than 120 over less than 80. Elevated is the name given now instead of prehypertension as 120 to 129 over diastole less than 80. You see the difference. Stage 1 hypertension is 130 to 139 over 80 to 89, while stage 2 hypertension is anything greater than 140 over anything greater than 90 millimeters of mercury. Now screening. Who should be screened? Everyone older than 18 should be screened once you are 18 or older at every clinic appointment, and every year you must measure your BP, just routinely, okay? If there are risk factors for hypertension, please don't wait till every year. Make it more frequent, every 6 months. Now, how do we measure the blood pressure correctly? Why is this important? It is important because the main instrument to make the diagnosis is our sphygmomanometer. I'll go into that in a bit. If we measure the BP wrongly when the person is not hypertensive, that will lead to unnecessary, unwarranted medications being administered, and the patient will be dealing with the side effects of such medications. But if we miss the diagnosis as well, when the patient is hypertensive and we are getting figures that are below, and then we assume that the individual is not hypertensive when actually he or she is hypertensive, we will miss that diagnosis and the individual could come down with stroke, and the next thing might be death. So diagnosing hypertension accurately starts from the least that we will ever think of, that is correct blood pressure measurement using sphygmomanometers. There are 3 forms that I know of: electronic, aneroid, and mercury. Out of all this, mercury is the best, but some are concerned about the environmental issues as per the mercury inside. Well, I have not seen one that has been broken and the mercury being poured on the floor anywhere that I've ever walked, because mercury will be more accurate than aneroid, and even electronic sometimes could be unpredictable but helpful. Is helpful compared to someone who will not even use any to even know any value at all. So the mercury is the best choice out of the 3. So in many hospitals across the globe, mercury sphygmomanometer will be available. Okay, part A, when you want to measure the BP and want to measure it accurately, the person that will measure the BP and the person whose BP will be measured must be ready for that. So it's not that one will be in a hurry, like some patient will come to the clinic and say, oh, I'm in a hurry, I need to catch a flight, so please do this quickly. No. Be ready, be in a quiet room, get chair and sit. It's not you standing up and then just show the hand somewhere. Don't cross the feet on the floor, please. Don't be talking when that is going on. Relax for 5 minutes. No tight clothing at the end to be used. No. Part B is that there should be no anger, no coffee, no exercise, No smoking for 30 minutes before the measurement. Part C. The arm should be on the desk, arm at the level of the upper arch chambers. Locate the brachial artery at the medial part of the cubital fossa. Choose curve based on the size of the arm at 2.5 centimeters superior to the brachial artery. Be sure that the curve is covering 75 to 90% of the arm. Part D is that firstly, let's determine the systolic by auscultation. You can use either the bell or the diaphragm of your stethoscope, palpate the radial artery, and then inflate the cuff. Note the BP when the radial pulse will disappear. That is the systolic, by auscultation. Inflate above that systolic level up to 20 millimeters of mercury with a stethoscope on brachial artery. Then deflate gradually at the rate of 2 millimeters of mercury per second. The first critical curve sound is the systolic blood pressure. The moment no more critical curve sounds is the diastolic blood pressure. Part A. We will repeat the entire process on the other arm. Then we will record only the higher blood pressure. Repeat the entire process if the patient is visiting for the first time. Use average of 2 or 3 readings. We have to do the same when the patient is lying supine and when he or she is erect. With that, we want to rule out orthostatic hypotension. We must rule out medications that could have increased or decreased the blood pressure even before measuring the BP by taking simple history of medications already used. Repeat in the next visit until you can make the diagnosis of hypertension or until you can rule that out conveniently. Now, the first visit. Usually, hypertension is not diagnosed at this level, but you can make the diagnosis of hypertension at the first visit if you find any of the following. Number 1, if the blood pressure is greater than 180 over 110 or greater than 180 over 120, you can diagnose hypertension at first visit, right? If there is hypertensive urgency with BP greater than 200 over 120, there's no need to waste time anymore. Make the diagnosis. If there's hypertensive emergency, meaning the blood pressure is greater than 160 over 100 or the diastolic blood pressure is greater than 120 plus signs of end organ damage. Don't worry, I'll go into that later on. Then it is hypertensive emergency. If it is greater than 130 over 80 in a patient that is diabetic or having renal failure, because the target blood pressure in them is anything less than 130 over 80 millimeters of mercury. So when it is greater and it is an individual with diabetes mellitus or renal failure, that is hypertensive already. You can diagnose that. Isolated systolic hypertension can be diagnosed with systolic hypertension greater than 140, while diastolic is less than 90 millimeters of mercury. If we're dealing with elderly patient with less than 150 millimeters of mercury over 90 millimeters of mercury, that is not hypertensive. We cannot make diagnosis of hypertension in elderly man or woman with blood pressure values less than 140 over 90 millimeters of mercury. If not up to the hypertensive threshold, then we can advise that there should be the following. There's the need to have all necessary history taken today. We will do thorough physical examinations today, and certain tests will be done today. Okay, both laboratory and radiological investigations will be done today because this is the first visit, right? And the threshold for hypertensive diagnosis has not been reached. Just now rewind and get the values on the previous slide. Okay, so we'll go further after the history, physical examination, and tests have been done today. Then home blood pressure measurement or monitoring should start. The same with ambulatory. And then we will use office blood pressure measurement if the two above are not available. Okay, then we will advise the individual to come for the second visit 1 month after, and we will review the results of home BP, ambulatory BP, compare that to the office BP. We'll see how we can make diagnosis based on the following in a bit. Okay, after thorough history, that will go through modifiable risk factors and non-modifiable risk factors. We will ask about blood pressure history before now in this individual. And of course, family history when it comes to non-modifiable risk factors. Don't worry, we'll soon go through the entire list of risk factors in a bit. Of course, we will know the race by mere looking. We should know the gender, but we should ask the gender at birth and the gender the individual has chosen now, and whatever has transpired in between. The age, we'll find out from the bio data, and we can ask the patient to furnish that. The medications he or she is taking right now, target organ damage, we'll ask questions about that. Secondary causes, if this person is young, we'll say the reason in a bit. Social history, smoking, street drugs like cocaine that could shoot up the blood pressure and the heart rate, alcohol, large volume of alcohol being consumed over a long period of time, diet, indiscretion, sleep apnea. People don't know that obstructive sleep apnea could lead to hypertension. Well, you know, maybe. Now, physical examination will have gross appearance to be checked. Chest, we will do thorough cardiovascular and respiratory system examination. The abdomen will not be spared. Somebody is asking, what is the problem with abdomen and hypertension? Oh, really? You understand later on that adrenal gland, renal system, and abdominal aorta all could contribute to hypertension. Fundoscopy, there may be papillary edema, and neuro, all will be checked. Now, we'll embark on certain investigations. I will not go into that right here because there's a separate section for investigations that should be done in hypertensive patient or in anyone that would like to rule out hypertension, in him or her, will then embark on certain laboratory and radiological investigations. Since there's a separate section for that, I'll not waste your time here. Now, the second visit. This time, if we are now having the blood pressure that is greater than 130/80 and this person is diabetic, or the office blood pressure is greater than 140/90, then we can diagnose hypertension today. If home blood pressure is greater than 130/80, then we are going to make the diagnosis of hypertension today. If ambulatory blood pressure is greater than 130/80, we will make the diagnosis of hypertension today. Now, in the second visit, we'll be concerned about white coat hypertension if the first time we measure the blood pressure is pretty high, like BP is high while at the clinic with the doctor, like greater than 130/80, but Going through the record from home blood pressure, measurement and ambulatory blood pressure is below this value, then or is just grossly within normal range, then we'll conclude this is white coat hypertension, meaning the BP is only high while in the presence of the doctor or the nurse. So that is not hypertension. So that is why home-based and ambulatory will help us to rule out white coat hypertension. But there's another entity known as masked hypertension. We'll get into that in a bit. This is the second visit, and the BP with the doctor is within normal range. If the BP, the average of home BP and ambulatory BP is less than 130/80, then you can conclude that the three factors or the three figures, normal office BP, normal home BP, normal ambulatory BP, second visit, right? No hypertension in this person. But if they associate cardiovascular system or renal disease with other risk factors, then we should have ambulatory blood pressure, home blood pressure repeated, which means we cannot conclude today. Let me explain here. I'm not rushing. This is the second visit, right? The value of home BP and ambulatory are good, okay? The office BP, pretty nice. So you want to conclude no hypertension, right? But going through the history, there are risk factors. If risk factors are present, you cannot tell the patient today you are not hypertensive. The next thing to tell the patient is we will repeat these two. Home BP and ambulatory, we will repeat them. And then you come back and add the office also, because we cannot be comfortable with these risk factors to just rule hypertension out that way. Okay, second visit and masked hypertension. How do I mean? Today is the second visit, and the individual is right here at the clinic. The BP is within normal range, but the record from home and the ambulatory, values is pointing to something greater than what has been measured right now at the clinic. That is masked hypertension. That is pointing to the fact that there is something bothering this man or woman at the family level, or there is one stress somewhere that we don't know, but the affected individual is aware of, or could be job issues, or anxiety, or overexertion. So it's not going to be ordinary. Something is bothering him or her. We need to delve into that. Now, second visit, but no diagnosis. If you can't make the diagnosis yet, ask him or her to come back in 1 to 3 months for the third visit. Now, the third visit. If no hypertension is diagnosed yet after the second visit, then repeat the blood pressure today. If office blood pressure is greater than 160/100, then hypertension can be conveniently diagnosed today. We will keep the record and start treatment from non-pharmacological to pharmacological. Don't be in a haste. We'll get into all these medical jargons, full explanation in a bit. We will do nothing if the BP we are picking today, the third visit, is not so scary. For example, if it's greater than 130/80 but less than 160/100, we will do nothing, but we will advise against the risk factors and embark on non-pharmacological interventions. Okay, but If there are signs of end organ damage or this person is diabetic or having renal failure, then we'll embark on treatment. If that is not the case, if it is less than this or greater than 130/80, less than 160, no end organ damage, no diabetes, no renal failure, we will invite for the fourth visit and probably the fifth, at 1 month apart. Now, at fourth, fifth, or sixth visit, if the average BP is greater than 130/80 to 140/90, you can conveniently label this individual as being hypertensive. If BP is averagely less than 130/80, you can conclude that there is no hypertension. Okay. If less than 130/80, no hypertension is diagnosed, but must be doing something. So it's a good news. You've now count the first visit, second, third, fourth, fifth, and sixth. Persistently less than 130/80, then you can say, gentleman, lady, you are not hypertensive. But that is not to say you close the door. Annually, please come for checkup. Or anytime you have the chance to see the sphygmomanometer anywhere, please have your blood pressure measured at the pharmacist. Any clinic appointment, please have it checked. Now, hypertension, primary or essential hypertension. Essential hypertension is old nomenclature, primary is the new name. Here, we can't really come down on the cause or causes. In medicine, it could be referred to as idiopathic, meaning unknown cause. And this will account for 95% of all cases of hypertension diagnosed. The blood pressure values. Normal is less than 120/80 millimeters of mercury. Hypertension is diagnosed if ambulatory blood pressure monitoring is greater than 130/80. Home blood pressure is greater than 135/85. Office BP is greater than 140/90. The above target in DM is anything greater than 130/80 means hypertension is diagnosed if this individual is having diabetes mellitus. Hypertension is also diagnosed fully if this individual is 80 years and the BP today is greater than 150/90, that is hypertension, 80 years. So the older you become, the higher your BP, that is now the record is saying, okay? But isolated systolic hypertension could be diagnosed if systolic blood pressure is greater than 140 and diastolic less than 90 in Europe, or in America, if systolic is greater than 130 and diastolic is less than 80 in America, then you diagnose isolated systolic hypertension. This is very common among the elderly. You understand a bit. We'll get there why it is so. Now, new BP categories, that is 2017 guideline, is what I'll be adopting. Okay. Now, we will then define BP as normal if systolic blood pressure is less than 130 and diastolic is less than 80. We will say it is elevated if systolic is between 120 and 129 and diastolic is less than 80. We'll call it stage 1 hypertension if systolic is between 130 to 139 and diastolic is between 80 and 89. And we'll call it stage 2 hypertension if systolic is greater than 140 and diastolic is greater than 90 millimeters of mercury. That is the new category now from 2017 guideline. Now, the risk factors. You know one thing? A risk factor is anything that can increase the chances of developing a disease. Yeah, this is funny. Um, Actually, nothing is funny in diseases, but do you know that hypertension itself is tagged to be a risk factor because it's a risk factor to come down with stroke, heart attack, heart failure, kidney diseases, hypertensive encephalopathy, and so on. So hypertension itself is a risk factor, but there are risk factors that could predispose people to come down with hypertension. So let's have a look. Now, predisposing factors could be modifiable risk factors or non-modifiable. The modifiable ones means you can handle that, you can adjust it, you can treat them, you can bring them under control, like diabetes mellitus and all treatable diseases that can lead to hypertension. Smoking, you may choose to stop it. Lipid could be treated with your statins. Individuals with decreased activities can choose to increase activities now. Salt intake that is increased can be reduced. Stress can be adjusted. Social welfare people can be involved. Alcohol can be cut down. Drugs can be stopped. Poor diet, you can mean dietitian and have pamphlet. Obesity, you can have a workout and get it under control. So these are modified, you can modify them, but they are all associated with the probability of coming down with hypertension. The non-modifiable risk factors, meaning you can do nothing to alter it. It's there once and it's going to be there. Family history. So like first degree relatives, there's nothing you can do. You can wipe out your genes, even if you tell them, I don't want to belong to this family anymore. That is just by word of mouth or paper. Your gene is your gene. You can do nothing to change that. Age. Some will not want to grow old because they don't want to get into this problem, but you can change your age on a piece of paper. You cannot change it in reality, right? Race. Yes. Though hypertension is a worldwide problem, but blacks, African Americans, Caribbeans are going to pay more price. Yeah, if you are black, you are likely going to have hypertension more than whites. Okay, gender, male will have hypertension more than females, but among females, postmenopausal women will have equal risk like male counterparts. So it's difficult then to dabble into transgender or not. It's a sensitive area. I'm not delving into that. Now, still on risk factors before crossing to another section of this presentation, increased age with increased blood pressure is not the case in everyone. So don't be scared. So the fact that has been said right here doesn't mean once you are older, then you must have high blood pressure. No, it's not so with everyone. But if we go through our literature, the younger people will not have high blood pressure. When they do, we must look for the cause. Okay? The older you become, the higher the BP if you go through our medical literature. The heart rate is higher when you are younger than when you are older. Genetic and environmental factors are contributory to what will happen when you become older. Okay? Some believe that hypertension is not a disease, but it is just a risk factor for heart attack, stroke, retinopathy, renal failure, heart failure, even summed up to be for multiple organ failure. Many can tolerate increased blood pressure until a certain level of the blood pressure is reached, but damages may be going on gradually in the organs. Let me quickly explain this. And so many people can have values of blood pressure that is a bit elevated, and they will not show any sign or symptoms. When it comes to signs or symptoms, we'll explain that better. So let me just skip. So follow me to signs and symptoms. Now, still on risk factors, younger age groups will likely have increased cardiac output, not systemic vascular resistance, because blood pressure, when we come to pathophysiology, I will delve into that a bit, could be that you have increased cardiac output and systemic vascular resistance. In younger age groups, the problem is not systemic vascular resistance, it is cardiac output that might be their problem. Then, primary hypertension is likely multifactorial. Genetically susceptible people are likely going to be affected more with dietary sodium and stress more than the non-genetically predisposed. The explanation here is that if hypertension is not in your lineage, maybe you are Hispanic, Latino, or white, not black, and it's not in your lineage at all, then dietary sodium and stress may not be the risk factor that will tilt you to it. But if you are black, Caribbean, African, Americans, and hypertension is in your family lineage, and you are taking excessive sodium as you like, subjecting yourself to stress, either willingly or unwillingly, then the tendency to have hypertension is higher in you. Now, hypertension in the young. We don't expect the young people to come down with hypertension, but if that is the case, something is going on. It is secondary. And then we must find out what is responsible. Okay, hypertension in the young. You can see they are young. They are too young for this trouble. For how long will they live with it? Okay, we'll help them to find out what is going on. Young people will mostly have secondary hypertension, but it may be essential or primary or idiopathic. It might be white coat hypertension, or liver hypertension, which is occurring only at a clinic, with the nurse or doctor. In that case, 24-hour monitoring will fall short of the diagnosis of hypertension, and then, hurrah, no problem. Okay, then don't see me again, right? Really? Okay. But we have to pause. And why that? When a young person is having a high blood pressure, we have to rule out all possible causes. We have to. Until we've reached the bus stop, we've been able to make the specific diagnosis of what is responsible. Now, causes of secondary hypertension. I've decided to put this here because I've just introduced you to hypertension in the young. So something is going on, something is wrong. It could be primary or essential or idiopathic, but mostly a young man, a young woman is having hypertension, 25, 35, 45, hypertensive, something is responsible. Now, by definition, this is a form of hypertension or blood pressure that is caused by another disease or another condition entirely. The hypertension or the high blood pressure without a known cause is called essential, but that is not so common. It's about 10% of all cases of hypertension. Okay, you can suspect a secondary hypertension in a young patient with high blood pressure, meaning the secondary hypertension is not so common. In fact, some literature will put it as about 5% of all cases of hypertension. Some will put it at 10%. Don't let us underestimate. Let us assume that it's more, so that we'll be more concerned about it. We will not overlook it or brush it aside. Okay. What are the systems we want to be checking? When a young man or a young woman is right before me at the clinic with hypertension, something is going on. I will go and check the renal system. Is it renal artery stenosis, renal fibromuscular dysplasia in younger patients, or renal arteriosclerosis in older patients? Is it glomerulonephritis or nephrotic syndrome? Is it nephritic syndrome or polycystic kidney disease, renal parenchymal disease, or pyelonephritis? Am I dealing with trouble with thyroid and parathyroid gland? Now, thyroid disorders like hyperthyroidism, thyrotoxicosis, or am I with hyperparathyroidism right now? What is the value of the calcium telling me? Is this adrenal issue? In this case, Cushing syndrome with high cortisol level that will shoot the BP up? Or am I battling with pheochromocytoma, with sudden onset of headache, palpitation, sweating profusely, high blood pressure, and so on? Or could this be Crohn's syndrome, hyperaldosteronism? Is that what I'm dealing with? All this will be related to adrenal gland. Remember, hypothalamic pituitary adrenal axis is involved in hypertension. Could it be congenital problem, like coarctation of the aorta? We have to investigate. Could this be central nervous system problem with hypothalamic pituitary adrenal axis dysfunction? Might be there's central nervous system tumor, cerebrovascular accident, subarachnoid hemorrhage, or what's going on? Are there psychosocial stressors in this individual? Maybe he or she is just panic attack, or post-traumatic stress disorder. This military man or woman just returning from battlefield, and now the BP is up there, and you say, oh, he's just 32. No, the stress in his life is enough to give him that post-traumatic stress disorder. So that's why we'll not joke with any of them, that will appear and have one complaint or the other. Must treat everything seriously because of the psychosocial stress. Obstruction. Could this be as a result of sleep anomalies or abnormalities of obstructive sleep apnea? Could this be coarctation of aorta or aortic stenosis? We want to know. Are we dealing with metabolic derangement, like decreased potassium? Because the lower the potassium, the higher the blood pressure. But I'm not saying you should then go and buy all the bananas in the world, all the raisins in the world, all the broccolis in the world to get enough potassium in your system and then get into hyperkalemia. No, that's not what I'm saying. Everything in moderacy, please. Increased calcium, increased sodium. Sodium will retain water, right? In fact, we need calcium channel blockers to handle hypertension, right? Could this be congenital adrenal hyperplasia, or too much alcohol consumption, or deliberately increasing salt intake in the diet when the individual is having genetic predisposition already? So we want to find out. Now, could this be as a result of medications or drugs? Now, in fact, in North America, drugs means street drugs, and what you use to treat a patient are referred to as medication. But in neuro, everything is drug. That street drugs are called street drugs specifically in neuro. So street drugs like cocaine can shoot the BP. In fact, can give my cardiac ischemia, and you don't give beta blockers in them. There's a separate presentation for that already published by me. You can check my channel. No beta blockers in cocaine-induced myocardial ischemia or chest pain. Is this person on non-steroidal anti-inflammatory drugs that could retain water? Are you on tricyclic antidepressant with horrible side effects on the heart? Are you on steroids for a long time? Remember, cortisol level is high, the BP is high. Are you on the congestant with pseudoephedrine? Are you taking sodium tablets for any reason? Is there transplantation and you are taking immunosuppressants? Are you having renal problem and then your erythropoietin level is low and you are taking erythropoietin exogenously, all this could show the BP up. Disease-modifying anti-rheumatic drugs, that is why autoimmune condition is also considered during this presentation as per probable causes of hypertension. Okay, methylphenidate, alcohol, atypical antipsychotics, even typical antipsychotics could lead to hypertension. Amphetamines, and the list is endless right now. You can discuss more with a physician or your pharmacist or clinical pharmacologist. Now, signs and symptoms of hypertension. Before we go into that, I want you to take this along with you. Many times, there will be no sign, no symptom. Many patients diagnosed out of the more than 1 billion people living with hypertension, majority will be diagnosed on routine checkups. Yes. Only few people will have signs and symptoms, and when they do, it means the BP is pretty high, probably too high. Now, signs and symptoms. Essential hypertension will be asymptomatic most of the time. When you see signs or symptoms, then the BP is pretty high. It is accidentally discovered during routine checkups. The first sign in many people might be stroke. And when it is hemorrhagic stroke, it might be the end of life. Secondary hypertension will likely present with the signs and symptoms of the underlying pathology. I think you got that, okay? I've said mostly there will be no sign, no symptoms, but the following may manifest if the BP is not controlled, or this is just the first time or sudden rise in blood pressure that is pretty severe. Then we can be dealing with headache. There will be nausea or vomiting. There will be epistaxis, which was the case in an individual that came to our unit when I was in the Department of Internal Medicine during my internship at University Teaching Hospital. Now, he was concerned about the epistaxis. He didn't know what else was going on in the system. And when we measure the blood pressure, we say, oh, wow, this is what is responsible. No bleeding dyscrasia. This is hypertension. And you are lucky to be here right now. So we swung into action. Luckily, I went back home happy after. Dizziness, confusion, blurred vision, dyspnea, cough, meaning there's pulmonary edema right here. Cough, autopnea, or paroxysmal notional dyspnea. Okay, still on signs and symptoms, there may be edema, associated with chest pain, fatigue, hematuria, irregular heartbeats, heart pounding, diaphoresis, facial flushing. Now, signs of end organ damage. The other time I said, don't worry, when we reach there, I'll let you know. We're now there. Okay, in hypertensive emergency, there's high blood pressure greater than 160 over 100 milliliters mercury with signs and symptoms of end organ damage. That is hypertensive emergency. And that could be in renal system, that will be increased creatinine. A central nervous system, that will be autosensorial. And the ophthalmoscopy will show papilloedema and bulging disc. Then we are dealing with hypertensive emergency. Investigations. Remember the other time when I was about to delve into investigations, during the first visit, I said I would not go into that. Now we're there. Okay, let's see the investigations that we can have. Now, we'll head to the lab. For what? If we are lucky that the patient has not eaten in the last 12 hours overnight, we have fasting blood sugar down. But if that's not the case, under blood sugar. If the result is pointing to something scary, we'll order for fasting blood sugar and fasting lipid. We want to know what is happening to the kidney. Blood, urea, nitrogen, creatinine, electrolytes will be assayed. Complete blood count. Thyroid gland will be checked. Then vinyl mandelic acid is to rule out pheochromocytoma. Still, oh, okay, I'm repeating this, that's fine. Complete blood count. We want to know, because some people will present with epistasis, right? PT, APTT, von Willebrand factor, bleeding time, D-dimer. Want to know about clotting profile. Then urinalysis, toxicology. Now, remember we mentioned cocaine the other time. Pregnancy test, because of certain medication that we can give and we cannot give in pregnancy, and also there may be pregnancy-induced hypertension, preeclampsia that may later on end up in eclampsia, or HELP syndrome. That is hemolysis, elevated liver enzyme, and low platelets might be the case. So we want to be sure who we are dealing with and what is in the system. Cardiac enzyme, because we might be dealing with complications of hypertension already, like myocardial infarction. So what is the value of troponin I right now? Now, some will use troponin T, but troponin I is more specific to the cardiac cells. So liver function tests, dexamethasone suppression test. Somebody is asking, what's the business with it? Oh, do you remember the other time we went through cortisol level, right? And we said Cushing syndrome will have high cortisol level, and high cortisol level will shoot the BP up. So it is not out of place to ask for dexamethasone suppression test, because we want to be sure we are not dealing with Cushing syndrome. Of course, the Cushing fascia will be visible in anyone with Cushing syndrome, but just for academic exercise, so we can have that done. Then ACTH stimulation test. What's the business? Yeah, it's my business. Adrenal gland might be the one giving us this trouble, particularly in secondary hypertension, right? We just want to be sure. So we'll get that done, right? Because we want to know what is happening to the adrenal gland. Then we're still in laboratory, the atherosclerosis risk estimate, can have that done, because once we have this and the lining of the artery is thickened, then the force to pass through it will be higher than is responsible. That could be the case. Renal function test with albumin to creatinine ratio, if the center is well equipped to get that done, that will be great. Now, I brought this here. We have to rule out autoimmune diseases. Why that? I'll get to that in a bit. So let's have C-reactive protein, ESR, rheumatoid factor, antinuclear antibody, scleroderma 70, anti-DNA. This is for systemic lupus erythematosus. Let's rule that out. Now, radiologically, we can have EKG. Want to know if we are having arrhythmia here, what is happening? So do we have any ST elevated myocardial infarction or not? CT angiography for arterial stenosis anywhere, and magnetic resonance angiography. We just want to see the entire lumen, what's going on. We may or not call for echo to rule out left ventricular hypertrophy, but we should do that if this is a long-standing hypertension. If the patient has been on it for a long time, then we must rule out hypertrophy. So echo to get that done would be pretty helpful. Now, EKG for left ventricular hypertrophy or arrhythmia, yeah. Then ultrasound, for what? We can use ultrasound to rule out bruise, carotid bruise anywhere, aortic dissection, liver pathology, and renal pathology. Because with the CT and ultrasound, we can pick polycystic kidney disease, we can pick some other renal problems, and then ultrasound can help in making some of these diagnoses. Even CT can do the same. Now, chest X-ray. Part of the signs or symptoms that I listed was cough, autopnea, paroxysmal nostril dyspnea when there's pulmonary edema or there's cardiomegaly already. We want to be sure that is not the case. And then CT, that we have non-contrast, no, of the head. So remember, I stated that the central nervous system could be involved. There may be tumor, there may be hypothalamic pituitary adenosis dysfunction, and so on. Is there any problem going on in the brain? Want to be sure. And of course, vital signs machine for blood pressure, heart rate, O2 sat, and temperature. We can't read the pain yet. So people are still telling us all sorts of stories about pain as far as vital signs are concerned, but that is not for hypertension. So, okay, yeah, treatment. We've gone through so many rooms. We are now in the house of the pharmacologist or non-pharmacologist that will help us to treat this horrible condition called hypertension, a big risk factor for other terrible diseases. Okay, let's go. Before going fully into certain medications that could be used on non-pharmacological interventions, there are certain things that I want to point out. Although the pathophysiology of hypertension should be a separate topic, but I will just quickly brush this there so that we will know the reason or reasons why we are using each particular medication we are using. We are not just grabbing them for fun. No. Renal system helps in fluid regulation with pressure natriuresis that will be leading to increased sodium and water excretion and then decreased blood pressure. Okay, the renin-angiotensin-aldosterone system is comprising a set of hormones that will help in sodium and water excretion by the kidney. Now, renal failure is a big issue, okay? And that means these two mechanisms will be, in jeopardy, okay? The excessive activation of the sympathetic nervous system will be a big culprit, okay? So we use diuresis to reset pressure natriuresis, okay, to enhance normal blood pressure. Now, the renin-angiotensin-aldosterone system complex has anti-natriuretic influences on the kidney. And that is the reason with all this, we will be using diuretics to help. You've seen the reason now. The renin, there are renin inhibitors, and the angiotensin, we have angiotensin converting enzyme inhibitors or angiotensin receptor blockers. As far as aldosterone is concerned, we have aldosterone antagonist, spironolactone, and the rest diuretics that we use in hypertension. And then for renal failure that we don't want to occur, we can have ACE inhibitors that will be cardiorenal protective agent, Ramipri and the rest of them. And then for sympathetic nervous system, we use some centrally. We use some beta adrenergic, alpha adrenergic. You could see the reason why we use all these medications. So we are not just grabbing them for fun. Then increased vascular tone is the case when there's malfunctioning ion pumps. Then the ion pumps will be about the pumping of sodium, potassium, calcium, the ions generally. You can now see why calcium channel blockers will be pretty helpful. So you've seen calcium channel blockers, you've seen beta blockers, alpha blockers, centrally acting, sympatholytic agents. You've seen why we'll protect the renal system. You've seen renin blockers. You've seen angiotensin converting enzyme inhibitors. You've seen angiotensin receptor blockers. You've seen the diuretics, being used here. So the pathophysiology is responsible for the part we will go when it comes to the specific medications to be used. Now, the blood pressure goes when it comes to treatment is in diabetes mellitus patient. The BP must be less than 130 over 80 millimeters of mercury, then less than 180 over 110 if the individual is about to take thrombolytic agent. Okay. Then the age group target. Now, for example, if we are dealing with adolescents, then anything 90 over 50 to 120 over 80 should be the range. We don't want it to be lower and we don't want it to be higher than that. Okay. For middle age, 110 to 140 over 70 to 90 will be fine. And for most patients, anything less than 140 over 90 is fine. But American Heart Association has brought it down to 130, 125 over 80 thereabout. The goal is less than 130 over 80 in diabetic mellitus patient and most patients, 130 over 80 to 140 over 90 in elderly patients, in anyone with orthostatic hypotension, in someone on many antihypertensive agents. This will be the target. Because we are not just going to give this medication for no specific targets per se. There must be target. Okay, the BP target is important because we are going to titrate the level or the concentration of the medication or the dose of the medication based on the target that we are aiming at. Like in DM, we want something less than 130 over 80, but we don't want hypotension. And in the rest, we just want something less than 140 over 90. Now, we will not jump into medications. We will start with non-pharmacological intervention. So, decrease the weight. Okay. Here, we want to go over the modifiable risk factors and modify them. Okay. To the ones that are having sedentary lifestyle, increase exercise, increase activity. To the ones with dietary discretion, dash diet. To those who are taking salt too much, decrease salt intake to 1.5 to 2 grams per day. To those who are smoking, it's better to stop smoking. To those boozing, then let's cut down the alcohol, please, for your own good. And to those having stress, let's discuss what's causing the stress. Can we get the part out of that? Can we involve the social welfare to help? Let's address that. And if it is domestic abuse, it's a big issue. Let the appropriate quarter handle that. Now, pharmacological agents. The first thing or the first line here will be thiazides. Then angiotensin converting enzyme betas. If there is a reaction or the patient cannot tolerate it, dry cough, anaphylaxis, angioedema, and so on, then we'll go for others. Calcium channel blocker, dihydropyridines, but non-dihydropyridines. How do you mean? Okay. We will use dihydropyridines to handle hypertension, but we will use non-dihydropyridines, that is verapamil or diltiazem, if arrhythmia is present. Why that? I will explain further in a bit. Beta blockers. It is better to go for beta-1 selective, but beta-1 and beta-2 non-selective will be pretty helpful. And there are certain groups that will combine either this and this, or this and this, or this and this. So combination. I have a list also. Now, the medications for hypertension. You have so many classes to choose from. Okay, no need to waste time. Let's go. Now, thiazide diuretics, hydrochlorothiazide and chlorthalidone. Loop diuretics like furosemide, etacrinic acid, or bumetanide. Let me say something here. To those who are having pulmonary edema or massive edema, and you really need to send out that fluid, you go for loop diuretics. But if this patient is sensitive to sulfonamide, then you will not use furosemide. You go for etacrinic acid. The potassium sparing, remember renin-angiotensin aldosterone complex, the spironolactone, amiloride, and pleurinone are aldosterone antagonists. Remember, the definition is it is potassium sparing. So watch out for the value of potassium when you place the individual on this, because there may be hyperkalemia. And when there's hyperkalemia, we treat differently based on the value of the potassium. I have a self-representation on hyperkalemia right here. You can check my channel for that. Now, the beta blockers. Okay, beta 1 selective, example is atenolol or metoprolol. Many people will be familiar with this. Beta 1 and beta 2 blockers, that is non-selective, it's propranolol. Beta 1, beta 2 with alpha blockage is labetalol. Beta 1, beta 2, alpha 1 blockage is carvedilol. So labetalol is alpha 1 and alpha 2 blockage with beta 1, beta 2. But carvedilol will block only alpha 1 with B1, B2. Now, B1, B2 with intrinsic sympathomimetic activity is pindolol, while B1 selective with intrinsic sympathomimetic activity is acebutolol. So you can make this selection based on what you want to gain in the patient. So if there's heart failure associated with the condition, you can go for carvedilol. Now, angiotensin converting enzyme inhibitors like ramipril, perindopril, captopril, enalapril, lisinopril, quinapril. But if there's angioedema, then you change. Angiotensin receptor blockers, losartan, valsartan, olmesartan, candesartan, irbesartan. Many companies are combining these with some other medications. Now, dihydropyridines. The dihydropyridines are less effective on myocardium, but they are very good with vasodilatory effects on peripheral vessels. So good for hypertension and migraine and so on. The non-dihydropyridines will have inhibitory effect on the sinoatrial node and atrioventricular node. You can see pointing to effect on cardiac conduction and contractility. So when there is arrhythmia and you want to achieve rate control, either with hypertension or not, you go for non-dihydropyridine, that is diazepam or verapamil. As a matter of fact, verapamil is now on trial to handle early morning hypertension. Remember, cortisol will play a big role there. Now, calcium channel blocker dihydropyridines, amlodipine. This is pretty popular. Novask, nifedipine, pretty popular. Nicardipine in severe hypertension, felodipine. Non-dihydropyridines will be diazepam and verapamil. Now, diazepam for arrhythmias, verapamil for arrhythmias and morning hypertension. Alpha-1 blockers will be prazosin, doxazosin, and terazosin. To those who will be treating anyone with benign prostatic hypertrophy or hyperplasia, they will remember this. Centrally acting sympathomimetic blockers like metidopa or clonidine. There's a separate presentation on clonidine right here on my channel. You can click on that. Look for clonidine and then listen and get full information on that. DR.BEN'S or guanfacine, they are all centrally acting sympathetic mimetic blockers. Now, vasodilator nitroglycerin. We must be careful when we want to use this. We must be sure that the BP will not be shut down. So when the BP is 90/60 or below, we will not give it. Nitroglycerin, we are familiar with that because of its use in myocardial infarction, or otherwise known as heart attack, right? Okay. And sodium nitroprusside. Anyone on this should not take erectile dysfunction, phosphodiesterase 5 inhibitors medications like Cialis, Viagra, or Levitra. Why that? He would die right there. Sodium nitroprusside, isosorbate mononitrate, mostly useful in individuals with heart failure. Remember, hypertension is a single strong risk factor for heart failure itself. Then isosorbate dinitrate, mostly in heart failure also. Hydralazine, I'm familiar with this particularly in pregnant women. Guanetidine or reserpine, endothelin receptor blockers, Ozentine for treatment of pulmonary artery hypertension. Remember when I was going through the list of hypertension, the other time I said it's not only systemic hypertension, we have pulmonary hypertension as well. Now, statins. Okay. Antiplatelets. Aspirin, ticagrelor, dipridamole, or combination of the so will help preventing coronary artery disease. Now, combinations of some of the antihypertensive agents. Lotra is a combination of amlodipine and bezafibrate. That is calcium channel blocker, dihydropyridine with ACE inhibitor. That one will have thiazide with angiotensin receptor blocker. Cardoet will have calcium channel blocker with statin, atorvastatin. Luteinizine can say that. Tribenzol say that. In fact, this is having three. Angiotensin receptor blocker, thiazide, and calcium channel blocker. Vasorectic, tenoretic, atenolol, clothalidone, zestoretic, loperazole, and Ziac. Aldosterone receptor antagonists will be spironolactone, eplerenone, amiloride, triamterene. But we must be careful. There may be a high level of potassium here because it has the capability to retain potassium. Okay, and renin inhibitors will be aliscrene. Now, potassium and antihypertensives. We have to check the value of potassium if we have placed anybody on ACE inhibitors, angiotensin receptor blockers, potassium sparing agents like spironolactone, eplerenone, amiloride, or triamterene. We must check the value of potassium here. Sodium and antihypertensive agents. If anyone is on hydrochlorothiazide or chlorthalidone, we must know the value of sodium. There are certain scenarios that I'll quickly go over here. Now, if someone has gout, then we will not give loop diuretics or thiazide here. Why that? There's hyperuricemia, worsening the gout. In liver disease, we will not get close to metidopa. And if there is BPH, benign prostatic hyperplasia or hypertrophy, and the individual is having hypertension, please rush for alpha-1 blockers. If there's arrhythmia, then non-dihydropyridine calcium channel blockers, verapamil or ditasone will be pretty helpful. A diabetic patient or anyone with renal failure, then we should try AC inhibitors, and then if there's reaction, then we'll go for angiotensin receptor blockers. Okay, we're not done yet. Now we've reached another bus stop, and this time it's about complications of hypertension. Okay, complications of hypertension. Now, the brief glance will take us to malignant hypertension, hypertensive emergency, hypertensive urgency, the heart failure, hypertrophy of the left ventricle, ischemic stroke, myocardial infarction, hemorrhagic stroke, and death. So hypertension is possible to tilt anyone to ischemic stroke as well as hemorrhagic stroke. Now, bleeding or stroke as part of complications of hypertension. So there may be hemorrhagic stroke or intracranial hemorrhage, on account of which we'll need the services of neurosurgeon for decompression. There may be subarachnoid hemorrhage with the presentation of saying, no, this is the worst headache of my life. There may be epistaxis, and of course, ischemic stroke. As far as hypertrophy is concerned, with the aid of the echo, might be able to pick left ventricular hypertrophy, particularly in long-standing hypertension. And of course, there may be hypertensive cardiomyopathy. That could be picked on echo as well as chest X-ray. Ischemic heart disease might be dealing with heart attack or myocardial infarction, all put together as acute coronary syndrome with others. There may be heart failure. Okay, now massive edema, paroxysmal nocturnal dyspnea, autopnea, cough, even hemoptysis and so on will all occur here. Chronic kidney disease. Chronic kidney disease can lead to hypertension. Hypertension can lead to chronic kidney disease. So, when there's one, we'll check for the other. The artery. And the lining of the artery, tunica intima, can become thickened, arteriosclerosis. Then there may be aneurysm and even dissection, example, aortic dissection, as part of the complications of hypertension. Still part of the complication of hypertension will be memory or seizure problem. There could be vascular dementia or seizures. The ocular region or ophthalmologist will experience, their own side when they have patients, with them with visual difficulty and blurred vision. Then there might be hypertensive retinopathy when the retina is damaged, or optic neuropathy when the optic nerve is damaged, and there may be blindness. The reproductive system will not be spared from complications of hypertension, like erectile dysfunction, or decreased libido, or vaginal dryness. In pregnancy, there may be preeclampsia, and if it is not properly managed, that could progress to eclampsia. In the lungs, may be pulmonary edema. And the chest, there will be chest pain. The chest pain here could be as a result of anything like heart attack, pulmonary edema, heart failure, and so on. Emergency cases in hypertension. There is an entity known as hypertensive emergency. I'll go into that in a bit. And another malignant hypertension. Here with hypertensive emergency, there will be signs of end organ damage, but there won't be signs of end organ damage with malignant hypertension, but then the blood pressure value will be pretty high that will warrant referral to emergency room, and then cardiologists will be contacted. Hypertensive urgency means the blood pressure is high. You need to do something. This is not the patient I'm going to send home to go and sleep, but it's not hypertensive emergency yet because there is no organ damage or no signs of organ damage. There may be arrhythmia, and of course we have a calcium channel blocker, particularly the non-dihydropyridines, ready because they have inhibiting effect on sinoatrial node and atrioventricular nodes, giving us rate control in arrhythmia. And finally, on possible complication, there may be death, particularly sudden death. Like I said, the symptom that some people will have for the first time is stroke, particularly hemorrhagic stroke when the BP is pretty high, or epistaxis, or sudden headache in case of pheochromocytoma. But you can have headache also even if you don't have pheochromocytoma if the value of the BP is pretty high. Yeah. Now, cortisol and hypertension. Someone is asking, Irma, what's the problem? Why are you so bothered about the value of cortisol level and hypertension this much? Yes, I do. I'll tell you in a bit. Okay, like you've seen this slide before, but I'm taking it with all seriousness that cortisol has relationship with the BP level. Remember, cortisol rises at early hours, early morning, peaks at about 6-7 a.m. in the morning, and it's related to, or regulated by hypothalamic pituitary adrenal axis. So if there's problem at the hypothalamus or pituitary, and then causing problem at the adrenal axis, then there'll be problem. It shoots up at early morning, and then cortisol is a major factor in the timing of early morning hypertension. Okay. The brain will have the control, is going to regulate this. The hypothalamus will send impulse to the pituitary will send impulse to the adrenal gland. Now see where the adrenal gland is. On top of the kidney. Okay. So cortisol is produced here. Then high cortisol level will be found in Cushing syndrome. And Cushing syndrome is associated with high blood pressure. So that is not out of place to think or categorically state that high cortisol level will shoot the BP up. Because low cortisol level in adrenal insufficiency will bring the BP down. So low cortisol level, low blood pressure. Now, autoimmune condition and hypertension. Why am I so concerned? Inflammation would destroy the endothelium, and the entire lining of the blood vessels will be destroyed, thereby altering the layers and the tone of the lining of the blood vessels. Drugs for the treatment of autoimmune will mostly increase the blood pressure. For example, in the autoimmune conditions, you might prescribe non-steroidal anti-inflammatory drugs, glucocorticoids, or disease-modifying anti-rheumatic drugs. If you do, all these medications might shoot up the BP on their own. So even if you don't think that autoimmune will directly contribute to high blood pressure, then indirectly the treatment of autoimmune will do. Some centers are using ACE inhibitors and angiotensin receptor blockers in systemic lupus erythematosus, and they are getting good results with decreased renal damage and decreased atherosclerosis. So many medications meant for blood pressure management is actually helpful in some autoimmune conditions. So autoimmune can directly destroy the lining of the blood vessels, thereby altering the layers and the tone inside there. And the treatment can also shoot the blood pressure up, and certain medications for the control of blood pressure are really helping in controlling autoimmune conditions. Remember, once you find one autoimmune conditions in internal medicine, you look for other autoimmune conditions. Resistant hypertension. Why is the BP not responding to the treatment given? Okay, remember the blood pressure goes GM patient less than 130/80, no, less than 180/110 when the individual is about to take thrombolytic agent. Then, depending on the age group, you can target 90/50 to 120/80 in adolescents, and the middle age man or woman is 110/70 to 140/90. And then most patients is anything less than 140/90 if it's not hypotensive anyway. So this is the target, right? Okay, then what is the problem with resistant hypertension? Oh, don't worry, we'll get that in a bit. Okay, now, hypertension has been diagnosed in this patient, already on the treatment, then lifestyle modification already back upon, then medication has been added on top of that. Then secondary hypertension with the primary cause already identified and treated. So you've done what you're supposed to do, right? Okay, let's see. Now, the target blood pressure is already set, but the target blood pressure is not reached, despite all the interventions that you have put in this. Then you begin to wonder, what's happening? Resistant hypertension? So resisting everything you've done? Let's see. Now, the BP has remained high, and not just high, it is concerning. So it is more in those with associated comorbidities like renal problems or endocrine problem. You know why? If you have not addressed these problems, you cannot get out of the problem. So there will be that resistance to everything you are doing, and it will remain resistant hypertension. It is also common in elderly patients. Now, remember pseudo-resistant conditions, meaning this is not truly resistant hypertension per se, because there are other confounding factors affecting the value of the blood pressure. 1. Clinical inertia. What we are dealing with now is that we want to find out that this is not that the BP is resisting the interventions, it's because some things are actually wrong. When medications are inappropriately prescribed, like suboptimal dosage is being prescribed, or incorrect medications have been selected, then the overall outcome will be below the expected goal, and we think it is resistant hypertension. I just ran through a small example the other time that if this is the case, you go for this. I will get into some in a bit. I don't want to jump the gun, right? So other condition that could lead to pseudo-resistant hypertension will be over-the-counter medications. You are doing the right thing as physician in charge. You selected the appropriate antihypertensive agent for this patient based on the history and the findings, but unknown to you, he or she is taking certain over-the-counter medications, non-steroidal anti-inflammatory drugs, cough syrups containing pseudoephedrine and so on, and the BP is not being controlled. How would that be? Inadequate lifestyle changes. You've told the patient, no more alcohol, no more smoking, decrease salt intake. Now, I don't know. Maybe the individual has thought that he or she is hurting you by doing all these things behind and thinking that you are the one being hurt. I don't know. But one way or the other, you are not on the same page. What you told the patient to be doing, maybe he or she is truthful enough to tell you, I'm not doing it, or I'm not doing them, or deceiving him or herself, thinking he or she deceiving you by going behind and doing it and telling you he or she's not doing it, like taking more salt, drinking alcohol, smoking, or secretly, well, the BP will not be controlled. And non-compliance with medication might be this person doesn't even, maybe this person is confused, cannot take medication at the prescribed time and dosage, or there's no money to refill. So you get information from the pharmacist on that, then from family members, no, and so on, or serve attending to the person. Okay, all the above are raising the BP. All this clinical inertia, over-the-counter medications, inadequate lifestyle changes, non-compliance medications will raise the BP, making the treatment to be ineffective. Hence, the blood pressure will remain high. Now, we have to reflect on certain things when it comes to resistant hypertension. Is this a correct diagnosis? That's a big question. We must measure the BP over and over, and we'll make sure it's measured correctly again. Please pause, rewind, go over how to measure the BP accurately. Then we can use ambulatory blood pressure measurement. Could this be white coat hypertension? Yes. So if that is the case, let's send the patient back to have ambulatory blood pressure measurement and home blood pressure measurement. Okay. Have I done enough as per the treatment? We go through the medication again. Have I selected the appropriate ones? For example, correct hypertensive chosen here will be example phentolamine for pheochromocytoma. So if you are dealing with pheochromocytoma, it's not the best thing to be looking for other medications outside phentolamine or phenazobenzamine. Phentolamine for pheochromocytoma, that is a correct medication for correct condition in this patient. If you don't go for phentolamine or phenazobenzamine, you may not be winning over pheochromocytoma. Whites, blacks will suffer more than whites when it comes to hypertension. Whites will do well with AC inhibitors and beta blockers, while blacks will do well with dihydropyridine calcium channel blockers like amlodipine, nifedipine, and diuretics. Yes, the battle with fluid, the more. That is not to say you cannot give diuretics in white or you cannot give beta blockers in black, but if you want to be more exact, whites will thrive more with AC inhibitors and beta blockers, while blacks will thrive more with dihydropyridine calcium channel blockers and diuretics. In cocaine, you are not going to win if you give anyone with cocaine and beta blockers and you think you are treating the hypertension. No way, you are not going to win. That BP will be skyrocketing because it's like two people are fighting. You are holding the hand of one, and then the other one is free to keep throwing the punches. So alpha will start working and shooting the BP, off the roof when you give beta blockers in cocaine-induced, hypertension, tachycardia, or, myocardial ischemia. So, non-dihydropyridine calcium channel blockers can be used in cocaine-induced. So these are just few examples of appropriate selection under appropriate conditions that could prevent pseudo-resistant hypertension. Okay, still on reflection, is there any new medical problem not yet known by me? Yeah, we ask ourselves, right? Okay, am I dealing with increased sympathetic stimulation? Is fear in this person? Is this person having panic attacks, stress? If we're dealing with all this, medications can help. Even benzodiazepine may be helpful, but then he or she will need psychotherapy at the same time. Because when you give your medication and you curtail the situation for this moment, how about other moments after the individual is back to life? So, is this person on stimulant? It's time to drop. Is this person on cocaine? It's time to drop. This is time to reduce the caffeine to the barest minimum. Oh, yeah. Still on reflection, are we even dealing with fake drugs or wrong drugs entirely? Oh, yeah. You should find out. And that is not common in advanced countries in the Western world, but it's pretty common in so many other parts of the world that some people that are quick to make money and make money so fast can package fake items inside capsules and name it good anti-hypertensive agent. Or there was a case that I experienced in the past, no, in my unit anyways, not me directly, fake antibiotic rifampicin that didn't work. So it's possible. So check that out. Request to seek the drugs yourself. Get info from pharmacists or try another store to get the same medication if you are sure you've chosen the right medication for the right patient. Still on reflection, if it is a secondary hypertension, is the primary cause already addressed? We can answer that. Maximal dosage of the chosen medication reached? Found out from pharmacist. Are we using multiple medications, like 3, 4 different ones, with one of them being a diuretic agent? Why did I put this here? In all hypertensive patients, diuretics will be pretty helpful. If you are going to use one medication alone, it's likely it's going to be diuretics. And if we are going to use two, it's likely to be one diuretic with another medication. Compliance on the part of the patient. Now, lifestyle modification probably followed. They may not, but you want to find out any cognitive impairment that is not helping them to take the medication, the right dosage, the right timing. Is there depression in this person? Because depressed people won't do right thing the other time. Not that because they're mad at you, but sense of guilt, sense of worthlessness, thinking about ending it all and so on, might set in, and then they won't follow the instructions. It's not their fault. Then financial status, no money to even buy the medication. So abuse, yes, this is a big issue. This is an elderly man, living with, or the family member is living with him or her, or there are people coming in and out as staff helping him or her. No, be careful. They may not be administering those medications. They may be stealing money that is meant to buy this medication and be telling lies. Get information from the pharmacist about refilling, whether these medications are getting out and they're getting to the patient at all. Sometimes you send requisition and nobody will even call to get the medication at the other end. So, and then they're back after 1 month and tell you the BP is still off, it's not working, you don't know what they're doing. Then you find out if they know what they're doing, but you don't have to say it anyway, so just find out from the pharmacist. Okay. We will then ask about risk factors. We will review the risk factors again. Is this person losing weight? What's happening to diabetes mellitus? Is the lipid being controlled? Is this person still taking salt? Any smoking, any alcohol, any sedentary lifestyle? We want to see that non-pharmacological interventions are really followed, and then we're working against the risk factors. Any sleep apnea, hyperaldosteronism, Cushing's syndrome, photochromocytoma, coarctation of the aorta, renal artery stenosis, hyperthyroidism, and hyperparathyroidism, hypernatremia family issue. We'll go over everything. Do you know what? We just want this BP to be getting down. We cannot just be comfortable that, okay, we are doing everything and we're not winning. We'll continue to work till we are winning, because this BP cannot be allowed to stay up there. Now, effects. When the BP is not being controlled, it's like you are leaving the blood pressure untouched. Then there'll be more adverse outcomes. There'll be increased morbidity, and that could include stroke, ischemic heart disease like heart attack, hypertensive heart failure, renal failure, and the individual may even die. The intervention that we could embark upon immediately we know we are dealing with resistant hypertension is identify the cause. Okay? If we identify the cause, then we must address that. We have to review the lifestyle and go over all the medications. Please come with all the over-the-counter medications you are taking, including herbs. And be truthful with me. Are you taking street drugs? Are you taking other prescription drugs from any other doctor? Maybe he or she is doing doctor shopping. How about alcohol? Are you smoking cigarettes? Must find out. Then review the antihypertensive agents to be the correct ones, add more or change, discuss with pharmacists in case of synergistic effects and side effects of drug-drug interaction. Refer to the specialist after you've done all the above. Now, hypertensive emergency. By way of a brief definition, hypertensive emergency means there is a very high blood pressure with signs of end organ damage that will be needing emergency intervention to lower the blood pressure. But we cannot crash the blood pressure. We cannot crash it. Oh, good. Note, we cannot crash the BP. The first 1 hour, the BP can be reduced by about 20%. For example, if the BP taken initially was 220 over 120 millimeters of mercury, the first 1 hour must not be less than 180 over 100 millimeters of mercury. We can't crash it. In between 24 to 48 hours, we need to have reached about 130 to 140 over 80 to 90. That is in the first 2 days. Also, we should know that not everyone with high blood pressure is qualified for the emergency treatment. If there's no end organ damage, then there's no rush to treat this as hypertensive emergency. We should use intravenous medication with extreme caution. Cautiously. Don't admit if this person is asymptomatic. Okay? So, the BP is high, but there's no symptom. Well, you can observe for a while, but you don't have to keep the person on bed for indefinitely. If you crash the BP, then you will run into certain trouble. Because somebody is saying, then if you crash it, what's going to happen? Something is going to happen. There may be stroke, be transient ischemic attack, maybe orthostatic hypertension, and frequent falls with consequences, particularly in the elderly. Actually, anybody that falls, you don't know what may happen to him or her. What are the symptoms of hypertensive emergency? The symptoms are what the patient will tell us. Okay, we've measured the BP, it's pretty high, right? Then the patient can say, I've been having chest pain. No, and they will tell us the complete signs and symptoms of heart attack. They've been having difficulty breathing, having headache, they are confused, become restless, agitated. Other symptoms will include loss of visual acuity. I can see well. I feel weak, and then my tongue has been twisted. Then my heart is racing. I can't remember stuff again. I had convulsion. Then the signs of hypertensive emergencies, you'll be able to pick stroke, subarachnoid hemorrhage, increase in the cranial hemorrhage, left ventricular hypertrophy, heart failure, aortic aneurysm, aortic dissection. pheochromocytoma crisis, palpitation, sudden headache, sweating profusely, high blood pressure, and so on, coronary artery disease, delirium, severe preeclampsia in pregnant women, even eclampsia with convulsion, and retinopathy with papillary edema, when you have the thermoscopy done. Then you can also pick microscopic hematuria, pulmonary edema, albuminuria, atrial fibrillation, already pain itself, and of course hypertensive encephalopathy. What could be the possible causes of hypertensive emergency? Stopping antihypertensive cold turkey. Oh, that's bad. Someone is already diagnosed with hypertension on the medications, but suddenly he or she has decided to stop the medication without asking for pieces of advice from his or physician. Then you stand the risk of coming down with very high blood pressure and end organ damage. Pregnancy. This person is hypertensive, now pregnant on top of it. Anything may happen. So let the physician know, your gynecologist or obstetrician know from the beginning. Street drugs, cocaine. That's why it's not good to do drugs. Stop it. Live. Enjoy your life. It can teach you to hypertensive emergency and you might die. Decongestants is over the counter. Pseudoephedrine. You can overlook it, so it's a small thing, but with high blood pressure already in you and you're on this, you can be treated to hypertensive emergency. Anxiety, fear, panic attack, post-traumatic stress disorder, all this could treat you to hypertensive emergency. Tacrolimus and even pain. Still, part of the causes could include myocardial infarction with ruptured plaque, and it could be triggered by physicians during endotracheal intubation, or this person is on erythropoietin exogenously for anemia in chronic renal failure. That on its own can show the blood pressure. Aortic dissection, cerebrovascular accident, and cyclosporine because you need immunosuppressants in the face of organ transplantation. Investigations here. It's possible I could have just referred you to the page on investigations, but I'll quickly go through this so that when we are battling with hypertensive emergency, we know what we could quickly do pretty fast. You can have vital signs machine hooked up to give you the value of blood pressure, heart rate, O2 sat, and temperature. You don't have any tool to measure pain yet. CT with non-contrast, directed at the heart to see what's going on. EKG to get what's happening with left ventricular hypertrophy or arrhythmia. Chest X-ray to pick pulmonary edema. Ultrasound for aortic dissection, liver pathology or renal pathology. Urinalysis quickly, toxicological screening. We want to pick cocaine there or other drugs with or without echo. Can have cardiac enzymes done fast to rule out heart attack, because while you are trying to handle hypertensive emergency, the heart attack may kill the patient pretty fast. Electrolytes, blood urea, nitrogen, creatinine, complete blood count, APTT, this should be PT, APTT, von Brillouin factor, and bleeding time. Intervention. Please admit into the intensive care unit. But always remember, we cannot crash that blood pressure. Acute rise in blood pressure requires acute intervention, while chronic rise in blood pressure requires, let me say, chronic intervention, but that is not possible. We just say slow intervention because the adaptation that would have occurred cannot be altered faster than the way it has occurred. Now, still on intervention, the first hour, the BP can be reduced by about 20%. And I've given an example here. So you can pause and rewind the other time I gave explanation on that. And within 24 to 48 hours, you must have reached about 130 to 140 over 80 to 90, so you don't crash it. It's going to take several hours. And then don't go this difficult road alone. Involve the cardiologist. We can choose from strong intravenous agents to deal with this situation. Enalaprilat, phentolamine and phenozibenzamine if it is pheochromocytoma, labetalol, phenoldipan mesylate. Can also use clevidipine, nicardipine, hydralazine, nitroglycerin, and esmolol. Nitroprusside could be used, but that should be the last choice. In other words, it's not one of the medications that will rush to administer. We can give analgesic for pain, e.g. fentanyl, anti-anxiety may be needed if anxiety is peaked in this individual. Diuretics and hemodialysis, as the case may be. Now, return to other regular per oral antihypertensive after the acute case has been resolved. But don't use non-dihydropyridine calcium channel blocker in hypertensive emergency. Again, no verapamil here, no diazepam here. We're not done yet. That is just the end of this very bus stop. We are moving to another station. Okay, malignant hypertension. Accelerated or rapidly developing high blood pressure is known as malignant hypertension. This is going to occur suddenly without any warning sign or signs, with BP that could be as high as 220 over 120 millimeters of mercury. This is hypertensive urgency. There will be signs and symptoms of severe hypertension, headache, nausea, vomiting, blood vision, and so on. But there will be no signs and symptoms of any organ damage. If not, it will not be malignant hypertension alone that we're going to name it. It will now turn to emergency hypertension or hypertensive emergency. So that is the defining line between malignant hypertension and hypertensive emergency. Okay, because there will be no signs, no symptoms of end organ damage here. But the BP will accelerate pretty rapidly, and it's going to be pretty high. So we must add fast also. Now, accelerated hypertension. The BP is greater than 180 over 110 is also hypertensive urgency. There will be associated papillary edema, retinal hemorrhage. We must rule out pheochromocytoma. Pheochromocytoma will present with pallor, sweating profusely, labile and hypotension, with hypertension, postural hypotension, palpitations, and headache. Now we've reached another station and we need to stop and see what's happening with F syndrome. That will be hemolysis, elevated liver enzymes, and low platelets. By definition, F syndrome stands for hemolysis, elevated liver enzymes, and low platelets. This syndrome is fun in pregnant and postpartum women. Some regard it as a severe form of pre-eclampsia. That's why I brought it here. That hypertension could damage a lot of things. Okay. Some believe that it's a separate entity because some of the pregnant women with FEV syndrome don't actually have proteinuria or hypertension. 1% of all pregnant women will have FEV syndrome. Mostly white women, 25 years or older, will have FEV syndrome. Now, risk factors for FEV syndrome will include obesity, previous FEV syndrome, previous history of preeclampsia, non-specific genetic roles, antiphospholipid syndrome will increase the chances. The pathophysiology is such that the hemolysis will be secondary to high angiopathies when red blood cells will travel through the damaged endothelium and large fibrin networks. Still on pathophysiology, the elevated liver enzymes will be secondary to microvascular fibrin deposition and neutrophilic infiltrate, fatty infiltration, necrosis, and hemorrhage. The liver is damaged, sinusoid are obstructed, vascular congestion will occur, intrahepatic pressure will be increased, tumor necrosis factor alpha is released, and subsequently that will result in release of liver enzymes. Now the low platelets. It is secondary to thrombotic microangiopathies because the platelets are exposed to von Willebrand factor due to its increased concentration. Von Willebrand factor is increased largely due to decreased degradation proteins that are already lost in the urine. Now, the clinical features of FEV syndrome. First thing first, the woman will be pregnant, okay? And she will be at the second or third trimester. Then the onset will be pretty rapid, and it's going to worsen and worsen progressively. There will be pain. The pain will be epigastric in location. Now, moving up to right upper quadrants and colic in nature. The blood pressure will show hypertension. And that's why I brought this, phenomenon here. And some people will be asking, why are you bringing F syndrome into hypertension A to Z? Remember, I tagged it A to Z. So know everything, including pre-eclampsia and eclampsia. Though we will not go into details of that. I will just give you the link. In fact, stroke, hemorrhagic stroke, ischemic stroke, now all should be addressed here. Now, nausea, vomiting, malaise, and headache will be part of the clinical features. Still on clinical features, there will be blurred vision and retinal detachment, ascites, jaundice, DIC, abruptio placenta, acute kidney injury with or without proteinuria, pulmonary edema, massive bleeding from thrombocytopenia, and with dizziness or tiredness, lightheadedness, palpitation, pallor, oliguria, or anuria. Diagnosis. Can make diagnosis with complete blood count, blood group, and rhesus factor. Platelets count less than 100,000 per cubic millimeter. That is thrombocytopenia, right? Low platelets. Peripheral smear will show schizocytes and ball cells. Liver enzymes will reveal AST, ALT, LDH, and then liver function test will reveal bilirubin, INR, APTT, albumin, or glucose. Still on diagnosis, serum aptoglobulin will experience decreased level, and that will be showing us that there is an ongoing intravascular hemolysis. Blood urea nitrogen, creatinine, electrolytes, uric acid will be on the increase, and ultrasound for fetal well-being will be necessary. Now on aptoglobulin. Aptoglobulin will be decreased in intravascular hemolysis, and with that, it binds free hemoglobin. So value less than 25 mg per dl or LDH greater than or equal to 2 times the upper limit are pointing to severe hemolysis. In other words, the aptoglobulin will drop because it's binding free hemoglobin, while LDH will increase greater than or equal to 2 times the upper limit. LDH is, however, non-specific to intravascular hemolysis, but aptoglobulin is. The possible differential diagnosis of HELLP syndrome will include acute fatty liver or pregnancy. In that case, there will be increased white blood cell, creatinine, and acid level, with decreased platelets and decreased fibrinogen. Another differential will be hemolytic uremic syndrome, thrombotic thrombocytopenic purpura, preeclampsia, fulminant or severe preeclampsia. Other differentials will include aporemesis gravidarum. In that case, there will be increased ALT and AST. Also, there will be intrahepatic cholestasis of pregnancy with increased bile acids, increased bilirubin, and increased AST or ALT. Then another differential will be systemic lupus erythematosus. Now the treatment. The first thing is to review. Review the ultrasound result with laboratory results. Do a thorough physical examination and then stabilize the mother. You admit and check for the airway. Make sure there's no foreign body or secretion, and if there's any, take appropriate action, solution as it may be appropriate. Then the breathing, that is, what is happening to O2 sat, any central or peripheral cyanosis, what is the respiratory rate, how about air entry, any obvious deformation of the chest, is the chest moving with the abdomen, any deviation of the trachea. Then we move to the circulatory system, any fluid deficit right now, any signs of dehydration, skin toggle, how about capillary refill. Then what is the BP? What's the heart rate? What's the heart sounds? Is bladder catheterization in situ right now? What is fluid in and out? Then we determine whether or not the mother and the baby are stable. So we give IV fluid with or without glucose. Then the cardiac monitoring must continue. Then we have the blood pressure control with hydralazine or labetalol intravenously. You can see why I brought HELLP syndrome into this matter right now. We've talked about hydralazine today, and we've talked about labetalol today. Magnesium sulfate will be helpful for seizure prophylaxis. Then we have to catheterize the bladder and group and cross-match. So the third thing to do is emergency delivery. Cesarean section will be favored here. Is this pregnancy up to 34 weeks gestational age or greater? Then if that's the case, we can deliver the baby right now. If not up to 34 gestational age, but there's fetal death in utero, or acute kidney injury, or there's disseminated intravascular coagulopathy, or there's a aborted placenta now, then we must also deliver right away. Though not up to 34 weeks, but all these unfavorable conditions will not allow us to keep that pregnancy any day further. If it's less than 34 weeks, but without any life-threatening conditions, then we should delay the delivery by giving betamethasone for 48 hours, then would deliver immediately after 48 hours. We can deliver before 48 hours if either the mother or the fetus will become unstable. Now, repeat all laboratory tests after 48 hours post-delivery. Less than 10% will reoccur again, and death is likely going to occur in less than 1%. Now, prompt presentation with early diagnosis, in addition to appropriate interventions, will give us good outcome. Okay, I will quickly brush through useful links that will help in hypertension. I have full presentation on diabetes mellitus here. I tagged it diabetes mellitus A to Z. Everything you need to know from diabetes mellitus to diabetes insipidus, and the treatment, the symptoms, the complications, everything including hypoglycemia, all the different drugs for diabetes, full info on insulin, more than 2 hours, click on this link. For chest pain, heart attack, acute coronary syndrome, ST elevated myocardial infarction, non-ST elevated myocardial infarction, diagnosis, presentation, treatment, complications, prognosis, all here. Click on this very link. Heart attack, everything you need to know, can click on this very link. Obstructive sleep apnea. We've gone through part of the possible causes of secondary hypertension, and obstructive sleep apnea came up. So I've done justice to that. I have full presentation on obstructive sleep apnea right here. Even central sleep apnea, already published by me. You can get to that through this link. Now, central sleep apnea. Oh yeah, I just alluded to it there a while ago, right? Okay. Then Addison's disease. We've gone through the role of adrenal gland in hypertension, cortisol, and so on. Mineralocorticoids, regulating sodium and water, renin, angiotensin, aldosterone complex, everything we've gone through. All different conditions with adrenal gland, the adrenal gland itself, the adrenal insufficiency, Addisonian crisis, the symptoms, the diagnosis, ACTA stimulation test. You can click on this link to get the full pieces of info on adrenal gland and Addison's disease. Furosemide, we've gone through how helpful that diuretics could be in hypertensive patients. And we've also seen that we will not use high saline diuretics like furosemide when someone is having gout and hypertension. For full info on furosemide, uses, side effects, different forms, and so on, you can click on this link. Renal failure. Well, we cannot overemphasize the importance of renal system in body homeostasis, and that has reflected in its role as per hypertension. So chronic renal failure, acute renal failure, pre-renal failure, post-renal failure, all are already here. So you can click on them one by one, including end-stage renal disease. You'll get all the facts right here. Now, heart failure. Now, some believe that hypertension itself is not a disease, it's just a big risk factor to some other diseases, prominent among which is heart failure. So, I have done justice to heart failure by publishing a series of presentations on heart failure. And here I've included cease of diet. So you can click on this, including the role of entresto, even B naturopathic peptides, all already published by me. You can click. Even atrial fibrillation, full presentation on atrial fibrillation, causes, signs, symptoms, treatment, EKG, all already here. You can click on this for atrial fibrillation. Click on each of these for different topics, high output, heart failure, and so on, all already published here. Stroke. Yeah. Hypertension can lead to hemorrhagic stroke, to transient ischemic attack, to ischemic stroke. Everything you need to know as per stroke, lacunar stroke, lacunar infarct, stroke signs and symptoms, stroke treatment, all are already published here. The other time I emphasize the fact that you cannot use beta blockers to treat cocaine-induced chest pain or cocaine-induced myocardial ischemia or cocaine-induced hypertension. Yes, truly I did that. And here is the publication on that. Please click on this for cocaine and don't use beta blockers. If not, you're going to kill the patient. Now, we've gone through the fact that stress could be a psychosocial stressor in the life of anyone with hypertension. Since our goal is to make sure that hypertension is brought under control and is not progressing to lead to complications, then we need to know how to handle stress fully. I have a full presentation on how to reduce stress. This link will help. In pulmonary embolism, we've seen that hypertension, pulmonary hypertension, pulmonary artery, pulmonary vein, everything pulmonary have been mentioned in the course of this presentation. So you can click on these links to know more about pulmonary embolism. Seizures. Part of the complications of hypertension will be seizures. And then I have published a lot of presentations on seizures, but I've decided to put together here only those that are beneficial for hypertension. So if you want to know more about seizures, in fact, you should do by clicking on this, because it's not all anti-epileptic agents that will be suitable for all seizure disorders. Thyroid disease, thyrotoxicosis, hyperthyroidism, thyroid storm, and so on are already published by me. You can click on this particular link to get all information about that right there. Okay, the other time we said erectile dysfunction or decreased libido in women might be the complication of hypertension or even the side effects of the medication that could be prescribed. So, erectile dysfunction has been published by me, erectile dysfunction signs and symptoms, and erectile dysfunction treatment already published by me, so you can check this for that. Smoking cessation, yes, full presentation of smoking cessation is already here. I think I have two of them, but then one was edited because I improved upon the presentation. Right here, I think I've brought the link as per the one that is already edited. So on smoking cessation, because this is the strongest modifiable risk factors or strongest preventable cause of death in any human race in any region of the world, smoking. So if you can stop smoking, you will reduce ischemic heart diseases. You reduce the rate of which people die due to heart attack. So it's a pretty strong factor that should be addressed all the time. and then anyone with hypertension or not. Ramipri, yes. We've gone through angiotensin converting enzyme beta or angiotensin receptor blockers. Remember, we went through renin, angiotensin, aldosterone complex. We've seen renin inhibitors. We've seen angiotensin converting enzyme beta. Here is a prototype. Now, Ramipri. Now, useful in diabetes mellitus and renal failure, and pretty good in white people with hypertension. And here, when you click on this, you get all pieces of info on Ramipri. Then insomnia. Yeah, insomnia is right here because the other time we said resistant hypertension. You've done the right thing, you've given your medication, but unfortunately, there are some factors that you didn't know will be going on. Somebody's having post-traumatic stress disorder, anxiety, panic attack, and could not sleep, become restless, or there's domestic abuse. So something is wrong somewhere that is not so obvious to the populace, and then you don't address that, you may not be winning as per the control of that hypertension. So insomnia, here is the link for that. Now, clonidine, yes. Clonidine is fully published by me. You can click on this link to get all the pieces of information on clonidine. And then verapamil. Verapamil is non-dihydropyridine calcium channel blocker like D-tazone. This is a good medication to curtail arrhythmia because it has inhibitory effect on synovial node and atrioventricular node. It's also good, and right now is undergoing trial for the treatment of early morning hypertension. So verapamil is good, but it's not useful all the time, and even in cocaine-induced hypertension or myocardial ischemia, you can use verapamil, but be careful with the blood pressure and other side effects. The same with D-tazone. So here is the link to the full presentation on D-tazone and verapamil, and this on clonidine. Okay, the last bus stop. Wow. Though hypertension is a chronic disease, but it can be controlled. It may be difficult to be controlled, but with self-determination by you and cooperation with your doctor, that will be doable. We can reduce morbidity as well as mortality when there is that cooperation between the affected individuals and the respective physicians. So, you can titrate the medications with the value of the blood pressure, change or adjust as the situation may warrant. The best piece of advice is cooperate with your physician and get that stubborn blood pressure under your feet. With that, I've come to the end of this very long presentation on hypertension. You are free to leave your comments. Please kindly forward this to all your friends and acquaintances on your platform. We are here to work together to reduce stress and suffering in human race. Thanks for listening. Remember to share this. Remember to subscribe to my channel. I appreciate it.